All right, so we're gonna get started here. I know you guys probably all are familiar with Dr. DeCaro. We've had him on many, many times. You can catch all of the previously recorded webinars of his on our YouTube channel or on the website archive page. All right, so in case you don't know his life history, he has been practicing podiatric medicine for a long time. He has a private practice in Massachusetts. He has been president of the American College of Foot and Ankle Pediatrics since 2014. And since then, they've started a tradition of having an annual seminar in a national park. So each year they've done a different national park. This year in September, they're going to Rocky Mountain National Park in Colorado. So um, if you're interested in pediatrics, that's definitely something I think you should check out. I don't think they have a bunch of spots left, so you might want to jump on that because I know that that one fills up fast. And so he's basically our resident podopediatric expert, and I'm going to turn it over to him to get us started.
All right, thanks, Ann, and thanks to podiatrymeetings.com for having me on. My name is Louis DeCaro. I practice in Massachusetts. Hopefully, I've met most of you. Maybe I haven't met some of you. This is actually the first time that I'm giving this talk. And of course, the topic is connective tissue disorders and their impact of the foot. This is something topic I've wanted to give a talk on for many, many, many years. It's vitally important, especially if you want to specialize in the foot. That was a joke. We all specialize in the foot, which means that this is a very, very important topic, and we'll go over why. Any questions, of course, you can ask me at the end. You can always shoot me a private email at drlewisjames@gmail.com with any questions. I am not an expert at connective tissue disorders. I'm not a geneticist. I'm not a neurologist. But I take pride in once in a while diagnosing connective tissue disorders for a patient and sending them to the right person. And most importantly, early treatment of the patient with a connective tissue disorder. So this is a really great topic. Whether you specialize in kids or not, it's a great topic to understand. And my lectures, if any of you have ever come to them, for those who haven't, I'm not going to dwell on that many facts. You can look up facts with Perplexity. You can look up facts online. You can go back to school and review your textbooks. What I like to impart is a lot of good practical podiatry so that you can take back to the office and really start doing good for your patients. This meeting is co-sponsored actually by the American College of Foot and Ankle Pediatrics, as well as my orthotic company, Nolaro 24, who are the makers of Little Steps Foot Orthotics. And so this is kind of co-sponsored and allows me to be in front of you for an hour, thanks to those two corporations and organizations. Let's talk about ACFAP. Any of you interested in learning more about pediatrics, maybe send me a heart or some sort of flying emoji. Let me know. Any of you who have been to our meetings, thank you very much. We do our meeting, like Ann said, in a national park every year. It is by far the best podiatric meeting I would say, in the world. We've been doing it for 10 years now, and we have a lot of the leading experts coming to the meeting and lecturing and doing workshops. Like Ann said, it's special in that we do them in national parks. Once again, this is the 10th national park we'll be in. This is actually a national park I've never been in, which I'm very excited for. It's Rocky Mountain, and our hotel is right at the edge in Estes Park, Colorado. On Thursday, September 18th, we all have an outing into the national park where all the doctors and the corporate sponsors and anyone who comes gets on. This year, we're doing something very special. I'm not going to leak it, but we're doing something extremely special where we're all going to out in the park and just experience the park all day together. It's a wonderful pre-conference day that's included in the cost of the conference. It's a full day where you get to hang out with like-minded colleagues. It's a full day where you can discuss cases or anything you want. You can talk. It doesn't matter. It doesn't have to be podiatry, but you're basically commingling and enjoying a national park with all of us. And able to just kind of pick the brain of a lot of the leading experts in the world on pediatric podiatry. On the 19th and 20th is when we do our didactic. And I just want to go over a couple of lectures for you. I'll welcome everyone on Friday the 19th. And then we go right into the lectures. Patrick DeHere, a good friend of mine, a practitioner in Indianapolis. I'm sure you've heard him talk before, at lecture before. He's doing juvenile bunions. He's also going to be talking about some MIS stuff for kids as well. We have John Grady. He was instrumental in putting together many Region Threes, Midwest conferences, and involved at the school in Chicago. He's going to do sports medicine. Hannah Park did a fellowship in pediatrics and podiatry. She's doing pediatric pharmacology. She's going to talk about everything about dosing and conversions, and pre-op, post-op, just antibiotic treatment for kids, ingrowns, fungal. There's not a lot of talk out there about how you dose kids, and especially the young kids. And so this is an opportunity to really brush up on that. I'm very excited about that talk. Patty Larkin is an amazing woman. She's a CPED down in Texas, and she's probably one of the, if not the premier skate fitter, CPED, CPO in the country, and she does a lot of sports footwear. She's going to talk about fitting orthotics and braces and such in sports footwear and what to look out for. Michael Jarman, exclusive pediatric practice. All he does is kids. 100%. I always say I'd like to be Michael Jarman someday, but I let the occasional adults sneak in my practice. He doesn't. So he's going to be talking about like a huge range in-office procedures, like simple ones that you can do on kids, but then on the other end of the spectrum, he's going to cover ankle fractures. So as you can see already, there's a huge diversity and range from conservative to surgical. Mitzi Williams, she wrote the textbook on lesser digit deformities. John Bands is an amazing physical therapist who talks about the evolution of muscle function and structure in kids as they get older and how it pertains to the foot and how you order a PT prescription. Amazing, amazing stuff. Grace is making her debut. She's been a participant at our seminar, I think, for almost 10 years now, and she's going to talk about osteochondral defects. I'm going to be talking about in-toeing and toe walking. And then we just basically all get together at the end and we talk until really until they kick us out of the room. On the Saturday, we do our workshops. We're going to do biomechanics. We're going to do dermatology. We're going to do bracing. We have a really great day. So those are our 2 days that follow our outdoor event. Register online, acfap.org. There's a lot of information online. This is going to be our biggest invest meeting. I'm really, really looking forward to it. What Anne was referring to was that there are very limited spots left on the Thursday outing because we have such a special outing plan. It cost us so much money that we had to cap it. So make sure that you, if you're on this and you're on the fence, sign up within the next week and you should be guaranteed a spot. So we're going to be talking about connective tissue disorders. They're a group of diseases that affect the tissues that support and connect the body's organs and structures. They bind us, basically. These disorders can either be hereditary, which is genetic, of course, or acquired. So there's two categories of connective tissue disorders. So when you're talking about connective tissue disorders, the first thing you have to think about is what category of them are we talking about, hereditary or acquired? And they often involve all of them a dysfunction of the connective tissue, once again, which is basically the rubber bands and the glue and everything that sort of holds everything from just kind of collapsing and falling apart in our body. So let's talk about the hereditary connective tissue disorders first. These are probably going to be ones that you're more familiar with, ones that you run into in your office. or ones that you've heard in medical histories that you've taken. It is amazing when you start to look for connective tissue disorders in your patient's genetic profile, how often they come out. I could base my practice just on connective tissue disorders, and that is not a lie, not a joke. They are so prevalent, but we have a way of sometimes, not that we don't take a good medical history, but my medical history always delves into a full family history. Sometimes it comes up in our intake form. Sometimes it comes up when I look at a foot and I'm like, there must be some connective tissue disorder in the family. Or sometimes I just start talking with the parents and the other siblings that come in and we start talking about, bad feet and things that are inherited or circus tricks or things like that. So hereditary connective tissue disorders, these are going to be more familiar. Ehlers-Danlos is probably the number one most known hereditary connective tissue disorder. We're going to talk and isolate out that one. That's a group of disorders that affects collagen, which is hypermobility, stretchy skin, and fragile tissues. We'll talk about that. You've all heard of Marfan syndrome. I treat that probably the second most on here. That is loose and fragile tissues. That's going to affect more sort of kind of cardiovascular. I treat a lot of OI, osteogenesis imperfecta. Why do I treat all these things? Well, I mean, bottom line with all of this stuff, all these connective tissue disorders, and I'm going to say this probably 38 more times, but these all affect the full body, and the full body is predicated on how good the foundation is. So if you have someone with a connective tissue disorder, that is going to make their foundation, aka their feet, more unstable, and you need to stabilize them. We are responsible for stabilizing the rest of the body. So Ehlers-Danlos, everyone should be wearing orthotics. Marfan, everyone should be wearing orthotics. OI, everyone should be wearing orthotics. You want to decrease the chance of fall risk or injury in someone that's going to break their bones easily, you have to think about orthotics. And then Loeys Dietz, I don't see a lot of this, but one of the hereditary connective tissue disorders. So these are the hereditary connective tissue disorders. And I say that multiple times because there is a strong family history with these. Usually you're going to see one of the people in front of you or the parents are going to say to you, yes, I'm affected somehow by these. And you're basically, when the patient comes in, the child is coming in, you're talking right to the parents sometimes, and you're really sort of trying to drill down to where this potential connective tissue disorder is coming from. And I've had families, and I don't exaggerate on this, I've had families make an appointment. And when I say families, I'm not talking about mom and dad or brother, sister. I'm talking about aunts, uncles, grandmas, grandpas, you name it, make an appointment. I think one time we had 11 people in a family make an appointment just by uncovering these connective tissue disorders because they're so powerful. Connective tissue disorders are sort of the breakdown of the stuff that binds us, cause so much destruction to the foot and ankle and the rest of the body that a podiatrist is often needed. But making this diagnosis is key. Acquired connective tissue disorders, these are, you run into these a lot, but you probably don't think about, or maybe you do, maybe you're a lot smarter than I used to be, as rheumatoid arthritis as an acquired connective tissue disorder. You think, oh, rheumatoid arthritis, you know everything that goes into it, you know the drugs that you prescribe for it, but it actually is a connective tissue disorder in which creates a lot of instability, not just because of the arthritis. Lupus, scleroderma, mixed connective tissue disorder, and polymyositis. These are some of the other examples that you're going to run into. So if you hear any of these key words and you don't normally associate them with connective tissue disorders, and like I said, I think rheumatoid arthritis is going to be one that probably people are going to raise their eyebrows about. You probably will have some form of connective tissue disorder with a good family history with a patient with RA or lupus or scleroderma. So these are the acquired connective tissue disorders. This is everything. I mean, right here, this slide. As most of you know, I hope, maybe some of you don't, but my passion is early intervention. Early intervention. Correction is not a solution. Correction is something where we come in too late to a problem. We can prevent most stuff that we fix. My passion in pediatrics is prevention, good history, getting a child at a young age in your office, figuring out is there a connective tissue disorder in the family, getting the younger people in the family in where there's a history of this. Because due to ligamentous laxity, hypotonicity, kids with connective tissue disorders, these kids typically have poor foot biomechanics. They excessively pronate, they stand out-toed, they typically have poor endurance, they injure themselves easily, they have issues throughout their life, which is commonly associated with growing pains or typical, you know, overuse syndrome, things like that. But these kids, and then of course adults, but these kids are starting their life on an unstable foundation. And it's one thing that if a house has an unstable foundation, a house just kind of stands there. But think about our feet and an unstable foundation. We're moving all the time and how deleterious it can be to the body. Excessive foot pronation compromises muscle function as the body has no foundation to build on. Once again, something I say all the time, we need to get early intervention screening of the foot and ankle and foot typing of little kids at an early age to predict pain, to predict you name it. And, one of the things I think we do really great at our ACFAT meeting is we combine the conservative and the surgical. But I'm sort of walking around like the guy in the Savannah Bananas that wears the yellow suit, just sort of kind of hitting home the idea of early intervention. How many of you have not seen this slide? Kind of throw me an emoji, flying emoji there. Um, let's see how many flying emojis I see. How many of you have not seen this slide? Great. That means everyone has seen this slide. I love it. Oh, a few. Okay, good. So for let's see if I count 4, 5, 6, 7. Ooh, nice. This is my slide right here. This is it. This is how I grew my pediatric practice, and this is how we are able to make sure that we're getting in kids before the problems start. This is something where you have your adult patient comes in with lousy feet, lousy foot biomechanics. You ask these questions to these adults. Who gave you those feet and who did you give those feet to? Our foot structure, just like connective tissue disorders, are tied to our genetics. And if you have a patient tomorrow in the office who's an adult who has lousy feet, and you know what lousy feet are, right? You're going to do surgery on them. They got a big bunion, they have PTTD, plantar fasciitis, all those lousy biomechanical things we treat. You have to ask them, who did you give those feet to? And this is how I built my pediatric practice. And now in reverse, I'm getting the little kids in there. I said, who gave you those feet? And that's why I'm not exclusively pediatrics because I can't help myself with treating the parent as well. All right, let's go to the next slide here. It's all about the biomechanics. Once again, another slide I pound on every single lecture that I give. It's all about the biomechanics. You don't outgrow it. You compensate for it, or eventually you pay the price for it. Flat feet, you don't outgrow them. You compensate for them, and then you pay the price for them. Toe walking, you don't outgrow that. You compensate for it, and then eventually you pay the price for it. It's never too early. Think about all the motion and torque that a foot does on the rest of the kinetic chain, and it's a lot, and it starts right from the time that we begin to walk. Almost everything you see in your practice predicates itself on the biomechanics, on how The motion got that person there. The bunion didn't grow before it because it felt like it. The plantar fasciitis didn't happen because they're wearing bad shoes. The neuroma didn't happen because it just sort of popped out of nowhere and it felt like growing. It's poor foot biomechanics, and probably somewhere along the line, someone said it'll be fine. It was ignored, and now you have a problem later in life, and often you have to surgically fix it. So one of our sponsors is Little Steps Foot Orthotics, and I help design Little Steps Foot Orthotics, mostly for kids under the age of 8 or 10. And we're going to talk about a lot of little kids with connective tissue disorders. The good thing about connective tissue disorders in kids under the age of 8 or 10 is that typically you can control the issue with a deep UCBL of 30 millimeters or greater with some medial lateral flanges and some really nice medial rear foot posting. We designed this orthotic for a flexible flat foot, and there's nothing more indicative of a flexible flat foot than a patient who's young with a connective tissue disorder. And they were designed based on that bottom left picture you see there. A custom foot orthotic pretty much mimics a custom foot orthotic and often much better than a custom foot orthotic, not only because it's cheaper to the patient, you can get it to the patient right away, but usually the heel cup depth and functionality, the functional nature of the orthotic is usually better than most labs put out. You can see those bottom two pictures there. I mean, I see this every day in my practice. You see that bottom picture in the center of that kid with connective tissue disorder, that ankle collapsing, that subtalar joint collapsing, that foot abducting, and then you put a child like that in an orthotic that basically gets that heel out of valgus, controls the lateral column, controls the medial arch and skive with a little skive, and then boom, you have a foot that's not torquing, that's not twisting, that's not just degrading the body. Deep heel cup, lateral clip, and nice arch support. That's the key. Same slide, just blown up a little bit more. Here's a great example of a 1-year-old. I think maybe I've used this in another presentation, but this child has a family history of connective tissue disorder. I think he was 1, and just came in, saw the pediatrician. It'll be fine. He'll outgrow it. Was referred internally to someone else who put them in a brace above the ankle. They came in and we put them in I think this is actually a Little Steps Dupe UCBL. And I mean, started this kid on a track of success. I mean, think about that foot and that top left of that 1-year-old and the destruction and the torque that that's doing on the foot, the ankle, the knee. You know, the knee is only designed to go up and down. Just think of that torque that that foot is putting on the knee at such an early age, that muscle memory that's taking place. I don't know why more of us don't see more kids because it's there. It's there. Not enough are seeing them, not enough are doing this early intervention. But this is a lifelong pair of foot glasses for this kid. You know, it's common to see 1 and 2-year-olds who can't see well wearing eyeglasses, but it's not common for 1 or 2-year-olds who can't walk well or have ankle collapse or flat feet to be wearing orthotics. But it needs to be as accepted and it needs to be as prevalent. So these are some powerful slides. I mean, the mom was quite emotional when she saw her child standing like this for the first time and not tearing into the shoe, not collapsing into the shoe, being uncomfortable, not wanting to wear shoes. I mean, look, she's so surprised that she actually put her phone down, right? Oh, it's a joke, bad joke. Takes a lot for us to put our phones down these days. Probably some of you staring at your phone right now, scrolling while you're trying to half listen to me. See? Ah, I caught you. So let's talk about the most common connective tissue disorder that you see or you should be seeing. Ehlers-danlos, skin hyperextensibility. That usually is done in and around the wrist to test for tissue fragility, so delaying in wound healing. These kids, certainly adults as well, frequent sprains, dislocations, You see it all the time. It's so amazing when I interview these kids. Often they'll say, "Oh, yeah, I'm just clumsy. I sprain my ankle all the time, or I sprain this and that all the time." And they sort of chalk it up to clumsiness. And unfortunately, a lot of times, some of the doctors and the parents do as well, but we need to be better than that. Easy bruising. And then, of course, the key here, joint hypermobility. What is joint hypermobility? This is a lot of words on a slide. You can take a picture of it. I don't usually put this many words on the slide, but too much motion, right? But not everyone with type of EDS has joint hypermobility, so you have to be careful that they don't have to be necessarily hypermobile, but they can still have EDS. But their joints are they're too flexible typically, and they're unstable, instability, dislocate, sprain, you name it. They cause, of course, both acute and chronic pain. A lot of these words on the screen are sort of kind of obvious. Foot and ankle manifestations. I mean, here we go. Here's Captain Obvious here pointing out that, yeah, of course, they're going to have flatter feet, valgus heel, ankle instability, plantar fasciitis. You know, you can probably list 1,000 things on this slide. Um, but what isn't as obvious, what isn't as obvious is, and it's a classic mistake, the classic mistake is that we're thinking in terms of the foot and ankle. We are foot and ankle specialists, but there's more. There is, ready for this, more attached to the foot and ankle than just the foot and ankle. Often in my history, I am looking at back, hip, knee, all the other joints first, even before the foot. And the reason I am is that sometimes these symptoms manifest themselves in other parts of the body first. Kids, young kids with hyperflexibility syndromes, connective tissue disorders, poor posture, they stick out their stomach, they have a weak core, they're clumsy, or their hips are weak, their hips are turning in, they're turning out. There's so much more. It starts at the foot, and you can get a lot of foot and ankle manifestations. But don't forget about ask about the rest. And it's amazing how the body can compensate. Like I'll get patients all the time who come in and we're not diagnosing connective tissue disorder because I'm not a geneticist, but I'm seeing it. I'm referring them to a geneticist and I'm asking the mom or dad the same questions, but not just of the foot and ankle. Often I'll get parents where we'll actually diagnose them with a connective tissue disorders based on hip dislocations or hip popping or IT band syndrome or we see a lot of posterior tightness, plantar flexus, overcompensation of tightness of the posterior column to these connective tissue disorders. So we have to think more than just kind of the Captain Obvious stuff. Biomechanical implications. I mean, obvious again, lax ligaments, midfoot collapse, pronation, torque, muscle overuse, fatigue. I mean, these are obvious, but all over the body. But you want to get to these before they get all over the body. If you don't specialize in kids, but you run into a family member that you're treating as an adult who has a history of a connective tissue disorder, you really, I implore you to have them bring their kids in for early screening. If you need my help, I'm just a phone call away. You can text me. You can email me. Doctors send me pictures and videos of their patients all the time. And I can help you walk you through. And better yet, you can come to the ACFAT meeting September 18th to 20th. And we're going to be talking about connective tissue disorders. And we're going to be going over protocols for orthotics for that as well. Clinical exam, we want to observe foot deformities. You know my chart, the foot typing chart, the 6 foot types. If you don't, we're going to go over briefly later. The ED and F foot, those are the EDS feet. Um, skin examination for fragility, scarring. I don't do a lot of that, but that's part of it. Gait analysis, of course, and then the Baton score. Probably you have all heard of this. I'm going to throw two slides up about this. This is really the gold standard of getting the ball rolling on helping to make a diagnosis of a connective tissue disorder, namely EDS. So take a photo of this, stop scrolling for a second, take a photo of this. I'm not going to go over it point by point. But it's a point system and it's so easy to do. It takes like 20 seconds to do. I mean, maybe a minute. I don't know how we just do it so fast. Finger extension, thumb to forearm, elbow hyperextension, knee hyperextension, then forward flex. And then 5 out of 9 suggest generalized hypermobility. And then in children, a little bit higher, 6 out of 9. So this is a great slide to take a picture of. And then this is actually my favorite slide to take a picture of. Um, this is something that I think just it's easy to follow and it can be so helpful to those who may have hypermobility syndrome. So I like these two slides. I took a lot of time to make sure that I put my two favorites up there. One that explains it nicely, one that you can hand out to the patient too, and then one that gives you a really, really nice visual. So if you're going to get anything out of this presentation, this one as a tool, put this in your toolbox. Thanks for those thumbs up. I appreciate that's much appreciated. Oh, so check this out, right? Here we go. Okay, so here's my beef with connective tissue disorder. Now this is where I get fired up in the lecture, right? We're 34 minutes in. This is where I start to get fired up. Okay, so you did the Baton test, you did your family history, you did all this stuff. You're like a hero. A patient comes back and, they've been diagnosed and they went through genetic testing and all this stuff and they get this diagnosis. They have it, and now what? They ask, "Can you cure me? Give me a shot for connective tissue disorders? Can you call me something in to my local pharmacy? Oh, can you fix it with surgery?" And being that, I've been known to have a magic wand or two, can you wave that magic wand and make me better? And the answer is unfortunately not. The thing that kills me about the diagnosis of connective tissue disorders is that there's not a lot for the patient out there. And we're going to go over what is out there. But the number one person that someone with connective tissue disorder should see is a podiatrist who understands their biomechanics. The number one physician that a patient should see following the diagnosis of Ehlers-danlos, of a connective tissue disorders, is a podiatrist. Period. Case closed. So here is where a patient is typically sent. So with treatments, there's no cure, there's no pill, there's no shot, there's no magic wand. So what do these patients do? They go to physical therapy. Once again, a lot of words, but let's boil it down. Physical therapy. I mean, geez, think about it. Where do the orthopedists send everything they can operate on? To physical therapists. I mean, they're fabulous, but this is here. The geneticists are no different. Okay, go to the physical therapist. You're going to focus on strengthening muscles to surround the joints to improve stability. Holy cow. Now I'm extra fired up. So these patients are sent first to physical therapy, often, to strengthen muscles surrounding the joints that are lax, right? To improve stability. They're not wearing orthotics. So you're just spinning your wheels. What are you doing? That's why you must go to a podiatrist first. Occupational therapists love OTs. OTs are a big part of my pediatric practice. They rule. They're going to improve independence and comfort in daily activities. But once again, all these comfort in daily activities, these independent movement is all predicated on the foundation. Super important. PT, OT have to be pre you have to pre-podiatry them. That makes no sense, but I think you get my point. It's just like little kids who are in early intervention. What do I always say? You got to get their foundation set, and then you can start working on the hip strength, the posture, the core, all that. You have a kid, right? Gets this diagnosis, or anyone of any age. It basically means they have a poor foundation. The glue and the rubber bands that are holding everything together is collapsing. And you're going to try to make them stronger without supporting their foundation? You've got to be kidding me. So those are two of the treatments. Pain management? Okay. Well, pain management is one of the things where a patient is sent, but pain management is, it's kind of like a little bit too late kind of thing. Like I would hope that you could diagnose this before there was a lot of pain management needed. Now, I know that's not always possible. I don't wear rose-colored glasses, but certainly getting a patient with hypermobility, hyperflexibility, family history of connective tissue disorders in a podiatry office as early as possible is the most important thing. Lifestyle modifications, of course, exercising. Well, being able to exercise is predicated on the foundation. Good posture. Well, good posture is predicated on building a good foundation. Supportive footwear. It's all about the orthotics. Healthy weight and diet. That means exercising predicated on orthotics. Sleeping. I'm not going to say that's predicated on orthotics, but we could all use a good night's sleep. Okay, so surgery. I had actually asked Dr. Agnew, who's a close friend of mine, past president of the American College of Foot and Ankle Pediatrics. He may even be on. I saw him register, but surgery, as he always says, is reserved for severe, non-responsive cases. And there's risks. Poor wound healing, scarring, recurrence. So careful pre-op planning is essential. I mean, I would say that we could do a practice management seminar for one of the malpractice on hypermobility syndrome. In fact, if anyone is listening that wants to do that, I think that's a great idea. And Dr. Agnew says every time he lectures on this, I love this quote, and it takes a minute to sink in. Just because one joint is hypermobile doesn't mean they all aren't. Arthrodesis may be wrong. So it just kind of makes you think like you fuse something and then it goes somewhere else, and then you fuse that and then it goes somewhere else. And this is kind of the thought process sometimes of narrow-minded surgeons. And not all surgeons are narrow-minded. I'm a surgeon. I'm not narrow-minded. But there are those out there that don't know their biomechanics and need to know their biomechanics before they operate. And they can get themselves in a lot of trouble if they don't, unfortunately. Um, Motion's gonna go somewhere. And I used my sort of best slang on that one. The motion is gonna go somewhere. Remember that. This is a good slide, actually. Let's put that up. I use the word actually like the rest are lousy, but I like this one because this makes the surgeons that are the hardcore surgeons in the audience maybe kind of think twice. So what's your role? Early recognition. I mean, they don't call me the pre-embryonic DPM for nothing, right? That's what I want on my tombstone. I joke with my kids sometimes. I want this guy loved ketchup on my tombstone. But for all the podiatrists that come to my funeral, if any of you do, I want pre-embryonic DPM on there. I mean, I want to be the first pre-embryonic DPM. I want a early intervention before the process even starts. Yeah, that early. Collaboration with rheumatologists and geneticists to make the diagnosis. It's important. We are an important piece of the diagnosis process in both the recognition and then the early treatment. And then long-term supportive care, meaning like until you retire, you're going to be helping out that child as they grow with their biomechanics. Today, oh my goodness, today in the office, right? Talk about feeling old. Not only turning the golden age of 50 plus one yesterday, but I had a patient who came in that I casted for orthotics 23 years ago. 23 years ago, and I've only been practiced 25 years. Amazing. Full adult and was like a 1 or a 2 year old. I can't remember. Amazing. So that's our role. Early intervention. Early intervention. And I think we could just kind of, if this Zoom was a record player, we could just kind of put that on skip. Early intervention right now. You've all seen this slide. If you haven't, take a picture of it. This is a really good one because remember I talked about kids under the age of 8 or 10 with flexible flat foot, putting them in an over-the-counter or a custom orthotic. This is really nice age ranges for like a 1-year-old who's supposed to have about 6 degrees of valgus, and then so on and so forth. Now, not that this chart is thrown out the window with connective tissue disorders, but it kind of is in the sense if I have a patient who's coming in and they're scoring like an 8 or a 9 and they're getting a diagnosis, I'm going to protect them no matter where they are on this chart. Oh, good. I love it. We'll take questions at the end, but I think we got either a very angry participant or we have a good question. I can't see right now, but we'll get that at the end. I'll leave some time. So this is a nice chart here. Basically, the normal range is at 1 year old, 6 degrees of valgus, and then you take away about a degree or degree and a half per year. Hopefully, all of you have seen these slides. This inevitably is really what kind of fueled my passion for pediatric podiatry. On the left is our patented 24 functional foot types, and on the right is an easier to read 6 functional foot group uh, based on the 24, 4 foot types for every category, patented foot type methodology of adults 10 and over. All feet are on these charts. On the left, you're all one of 24 feet, and on the right, you're one of the 6 foot types. And this is really, really important to understand, especially when you're dealing with potentially connective tissue disorders. And on the chart, the right side of the chart, for those who have exhaustively heard me talk about this or Roberta talk about this, and if you haven't, go to podiatrymeetings.com and get some of our old webinars. But the BDF on the right side of the chart, those are going to be the really flexible feet. Those are the pes planus foot types. The D being the classic Fred Flintstone foot type, that foot that kind of splays out. This is the classic foot type with someone with Down syndrome due to that ligamentous laxity. A lot of D's with connective tissue disorders, Ehlers-danlos, D's all over the place. If you see a D, that splay foot that kind of splays out, you have to ask a good history. Family history for congenital disorders. The F, the F is the same as the D. It flattens out, but it also abducts. It turns out, it flattens out. That's that posterior tibial tendon dysfunction. That's that patient with Down syndrome who gets a little older and is neglected in the foot department. That's that patient with Ehlers-danlos that didn't get early intervention. That flat foot then starts to abduct, collapse, pronate, torque, and just this huge destruction all the way up the chain because someone didn't think to look at them. You get a patient with severe pes planus with abduction. You're asking a good history of connective tissue disorders, or you're asking the family, anyone in the circus at all. It's funny, sort of kind of anyone in the circus or anyone like a really good gymnast in their life, and it's amazing. It's amazing how many really good pediatric gymnasts I treat with connective tissue disorders because when you see some of these people do these splits and moves, you need to be unfortunately hyperflexible. So you have to protect them outside of the gym, if you will. Yeah, these are some videos. Those are covered actually in Roberta's last lecture. She was covering those videos. I'm not going to show them because of time, but check those out. She breaks down these D and F feet as they're walking. The E foot type, Anne always links, no pressure, Anne, but evolution of the E foot type. She usually shares this. I think it's actually on Podiatry Meetings, probably the favorite thing I've ever written. And yes, I wrote it, not AI. I wrote it back in 2022. And it talks about the destructive nature of the E foot type. If you haven't read Evolution of the E foot type, go to decaropodiatry.com, go to my publications. I know it's on podiatrymeetings.com somewhere. Find it, email me. Maybe even we can link it to this. I'm not sure. But this is a powerful article. And on my website, I also have a video that I did as well on podiatry meetings on this foot type. Check it out. If you want to get more into kids and you want to get more into connective tissue disorders because I'm inspiring you, this is the article you have to read. Gross motor delay, severs, shin splints, knee pain, hip pain, you name it. This is the foot. So here, over the age of 10, sometimes we're adding that 4 foot posting. That would be on the E and the F foot type. You'll know what I mean if you've seen that webinar. You've heard me lecture before. This is imperative for someone with connective tissue disorders to start thinking about extrinsic 4 foot posting. Extrinsic forefoot posting, not done enough in the biomechanics world. Look at that foot on the left. Look at that foot on the right. There's the orthotics. Look at that piece. I'm like trying to point to it, but I can't. I'll use my mouse here. I don't know if you can see my mouse when I share screen, but anyway, this is the extrinsic forefoot post. This is the thing that holds the forefoot up. It's huge. It's key. It's not huge. It's hugely important. Right. Thumbs up. Thanks. You got it. Oh, I got a video. I usually don't do videos in my, but this is an awesome video. Like, this is a connective tissue disorder patient that I made the diagnosis. I think it's a 13-year-old, if I remember correctly. But listen to me talk on this video. I'm going to play it now. Hopefully, you guys can hear the audio. Ready? Here we go.
All right, this is a 13-year-old with a history of right knee and hip issues. She's a dancer. This is her standing and resting calcaneal stance position. Can you turn around and face away from me, please? You can see the forefoot abduction. You can see the mid-tarsal collapse and the classic 18-22 foot type. Turn around for me, please. Now she's going to go into subtalar neutral stance. Can you roll out on your feet like we practiced? Good. And I want you to pay attention to her knees. Now go back to relaxing.
Look at those knees.
Turn in, up again.
Look at those knees.
Beautiful.
Wow.
What you can see here is the need for forefoot and rear foot posting.
See that gap
You can also
under the big
see
toe?
a nice arch form with proper assistance.
False, flexible, flat foot. Look at that. And if you don't support that forefoot, that foot is not being well biomechanic. I love that video. Next, I got two videos for you, actually. This is a rarity for me.
All right, this is
No, same video. Oh, here we go. Here's her emotion. Watch carefully. You ready? Thanks for the thumbs up. I appreciate it. That inspires me to add more videos in. I have such a huge catalog of kids and videos and pictures. I could do one just on that. But yeah, check this video out. This is a cool video. Boom, look at that pivot.
Heel whip on the way back.
You think that's good for the knees? I don't think so.
In
Watch the knees.
back
Watch them.
of her right
Boom.
knee more than her
Look at
left.
that internal rotation.
Knee pain.
Look at that hip abduction
You can
weakness.
also still see
IT
the heel
band
whip.
tightness.
One more
And-
time.
One more
And
time.
we're going to focus on the
Tight hip adductors.
whip.
All the way up the
Faster.
chain. SI problems.
back.
Hip problems.
Little
This is a
faster.
13-year-old.
Beautiful.
This 13-year-old with knee pain went to orthopedic and they were sent to PT. That's it. They took x-rays of the knees. X-rays look fine. Well, they're 13, right? Let's watch that video again. Watch them walk. It's fascinating. This is not rare. This is someone who has a little hypermobility, and you're seeing this all day. These patients often aren't going to you too because they're getting the knee pain and then they're going to PT from ortho and then they're wearing a knee brace and then that's it. And then they stop the sport because they get injured. They don't have to stop the sport and get injured. They can be fixed, not, I don't, that's a wrong choice of words. The injury can be prevented. The pain can be decreased and gone, and you can strengthen around it with a good foundation. Let's watch that video again, and I'll try not to interrupt myself.
Go. You can see the medial heel whip. On the way back, you're going to be able to see the torsion in, come on back, of her right knee more than her
Oh.
left, hence the right knee pain and hip
That's an
pain.
E foot
You
type.
can also still see the heel whip. One more time, and we're going to focus on the whip, whip, a little faster.
Look at that
Come on
hip whip
back.
too. That's why we call it the runway model,
Faster.
that hip swagger.
Beautiful, thank you. Go.
Awesome. Awesome. I won't torture you again with that video, but that's a great video. Yeah. Oh, I got a lot of good hand raising here, but I can't answer to the
Go.
end, so be patient. All right, 7-year-old Down syndrome. Look at that. Just stare at that frontal view and rear view. Look at that. Look at that. This patient commonly either not treated at all because they'll outgrow it, or that's a normal foot for someone with Down syndrome. Look at that abduction. Look at that subtalar collapse, the whole nine. Look, they're on their tippy toes. That top right one. Don't be distracted by the unicorn boots, which are kind of fashionable, if you ask me. Look at that arch. This is I think Pat Tahir, if you're on his social media, posted something about the FFF. I love that he's using that term, false flexible flat foot. There you go, right there. This foot is not flat. It is flattening. But you know what? If you don't treat now and you wait until they're an adult, it is flat. And there is joint destruction and there is breakdown and there is ankle collapse and there is PTTD and there is knee pain and there is hip pain and there is a weak core and there is laziness, there is poor endurance, all that stuff that comes with it. Here's the orthotic I made for this patient. You can see that 4-foot posting. Yep. Once again, you can see the unicorn boots. You can see my boring sneakers in black. Maybe I should get some unicorns for the office. And then ready for this? Are you ready? You sitting down? Yep. Thank you. Look at that. Wow. That's an orthotic. That's a 30 millimeter depth orthotic with a 4-foot post. Game changer. Life changer. I mean, I love this stuff. You get this in the office, you make a huge difference in a child's life, not only in the near term, but in the long term. I'm getting emotional seeing it. This is what drives me. This is what keeps me going. Don't worry, he'll outgrow it. That is why I have a bald spot developing because of that phrase. 9-year-old, there they are at 50, there they are at 80. It doesn't stop. The train keeps on rolling. It must be a really good rock song that I'm just quoted. The 9-year-old has the shin splints and mom has to rub the legs to bed at night. The 50-year-old has the knee replacements. The 80-year-old has the hip replacements. Don't worry, he'll outgrow it. I don't think so. You got to come to our meeting. It's just a bunch of me's in a room as and who have passion for pediatrics, and we can really teach you a lot of pediatrics. Go to acfap.org for membership application and annual meeting info. You can email me. Here's the lineup once again. Email me, shoot me some emails, and I'll give you my cell phone if you want to start using me for pediatric patients as they come in. And once again, thanks to the sponsors, ACFAP, as well as Nolaro. Makers of Little Steps. You can email info@nolaro24.com if you need more little steps or you want to start using them. And I am going to stop sharing. I won't stop sharing my excitement and enthusiasm and passion, but I will share the screen to you.
Awesome. Well, you did excellent. And I was following along and dropped the link to that e-foot type article in the chat.
Thank
And you
you.
are right, it's on our website. So very good job. What did we miss? Anything else?
No, we're good. We'll see you next time.
Thank you very much, Dr. DeCaro, for presenting the day after your birthday. You did awesome.
Thank you, and you
Love
take
it.
care. Bye, everyone.
All right. Good night.